If I can back up a little bit, we're talking about a group of patients, about 20% of all large myocardial infarcts go on to heart failure. And these patients are still poorly served by current medical therapy. We give acute stenting. We intervene quite early, often within the first 12 hours. We don't intervene after 12 hours. And then we give a number of medicines, and still we get heart failure. So there still is a rationale for trying to develop novel therapies for these patients. So that was the first rationale. The second rationale is that we had, over the last 10 years, developed extensive preclinical evidence in both small and large animal models, showing initially from stem cell therapy that stem cells were very effective, and then showing that a growth factor released by one of these stem cells was as effective as the cells themselves. So we pursued that further and showed that a specific very low dose of insulin-like growth factor was actually as effective as the stem cells, and we designed the trial around that. About 50% of the patient subset I'm talking about, they're still quite ill, but they're not the patients who come after 12 hours. So those between 2 and 12 hours, but they have to have significant dysfunction of their heart muscle at the time when we do the intervention with the stenting. So we then selected those patients and randomized them to 3 different groups, placebo and 2 doses of IGF-1, both quite low, but a 10-fold difference in the dosage. We randomized them to initial therapy, injection in the coronary arteries at the time of the percutaneous coronary intervention or stenting. They got it actually after the procedure was completed, and then we assessed a structural change in heart function based on cardiac MRI parameters. And the primary endpoint was ejection fraction, but the secondary endpoints were remodeling. So these were multiple endpoints such as LV volumes, LV mass, LV stroke volume, and infarct size. The findings were, not surprisingly, because it was initially a safety trial, so there's only 47 patients here. The first thing we wanted to show was that it was safe, and it is exceedingly safe. There were no major safety endpoints observed. The second was that the primary endpoint did not achieve significance, but we were pretty sure that in terms of the statistical power of the study, it was not powered to see this. We were more interested in the secondary endpoints because these would show us whether the structural changes we'd seen in animal studies, whether they were held true in humans. And we found that 3.5 out of the 5 endpoints were positive in these patients. Most significantly, the hearts didn't enlarge in the high-dose IGF-1 group. Secondly, the stroke volume, which is basically a hemodynamic equivalent of the volume changes, was significantly improved. And lastly, LV mass remodeled very much in the context of improved heart structure rather than the worsening heart structure that we saw with the placebo. So all of these structural changes we felt were quite consistent with the animal data and give a certain amount of hope that this trial should be at least studied in a larger number of patients. I think it's too early to say that it would influence clinical practice. I think we're at the phase 1-2 stage, but I think what we will now go on to do is do a much larger study, hopefully of at least 200 patients in each arm, possibly a little bit more. And I think we will then have the statistical power to actually assess both ejection fraction, but also reconfirm that these positive structural changes that occurred are impactful.